what you're...
This is Jason Sork once again for Health Assessment. We're going to be discussing about the abdomen. To begin with, what I'm going to do with Dad is I would be asking him questions regarding any history. Did he have any surgeries in regard to his abdomen? Also, I would be assessing his activity. How active is he? We would be assessing his bowel movements. Is he having problems with constipation? Is he having problems with diarrhea? Is he on any certain medications that affects him? Is he having any certain pain? Is there a history of like cancer in the family or anything like that? You're going to be looking for everything in regard to what would be affecting this examination. Now, to begin with, we're going to be doing an inspection. So I'm going to have Dad lay down. And as he's laying down, he would normally be wearing a gown, laying down. I would be assessing the abdomen. I'd be assessing to see the symmetry of the abdomen, the contour. Am I seeing any visible pulsations? Am I seeing any masses, any discolorations, anything out of the ordinary that would catch my eye? And like I said previously, I would be asking him, are you having any pain in any certain way? Okay, the difference between the abdomen and any other organ is, after inspection you do auscultation. Now with auscultation we'll be using the diaphragm of the stethoscope. With the diaphragm we're going to be listening to the bowel sounds. You use an imaginary line going straight through the umbilicus to the pubic area and going straight vertical line through the umbilicus to the right upper, right lower quadrants, left upper, left lower quadrants. I'd be listening to my father's bowel sounds, and when I'm listening, I'd be listening to a gurgle. Another thing of it is, with the bowel sounds, what you're going to be looking at is you would be hearing either like hypo, you'd be hearing about like maybe 5 gurgles, or you could be hearing maybe a good normal rate, or even hyper rate, like 30 or more. You would keep the stethoscope on that quadrant for a maximum of 5 minutes. Another thing you need to realize is there any guarding while you're doing this? You're looking at, with the bowel sounds, with absent bowel sounds, you're looking at that there could be some peritoneal infection that's probably going on, or anything such as maybe a possible appendicitis. Another thing we're going to be doing and auscultating is the aorta, the iliac and femoral arteries. Using the bell of the stethoscope, I would be listening for the aorta, and then which divides here to iliac. Excuse me, iliac's right here, sorry about that. And I'm listening to the femoral. Which I heard pretty well, and that's good. Okay, after auscultating the bowel sounds, the heart and everything, what I'm going to be doing, I'm going to be doing palpation. And what we're looking at the liver, the spleen, the kidneys. I'm feeling for any mass. I would start off with gentle palpation, very light palpation. And you're going to be looking at the expression of the patient. Is there any guarding, any grimacing? If Dad complained of pain in his spleen, I would save that for last. Then I would progress to moderate palpation. And feeling with my fingers, again, no problems. Then I would do deep palpation. Now some doctors like to use both hands, then others using a one-hand technique. And what you're doing, you're feeling for any masses, nodules, or anything like that. Okay, let's begin now with the spleen. We're going to be doing percussion. Actually, percussion's before palpation, I should say. With percussion, you're going to be feeling and listening for anything that would indicate that there's like fluid buildup or masses and stuff. Usually over masses you will hear a dull sound. Over organs you'll hear a dull sound. You usually hear resonance. For example, if I was feeling the abdomen, and percussing. I would hear usually resonance. With the spleen, where your rib cage is, the costal area, what I would be doing, I'd be hearing for dullness. I'd be using my marker and marking where I heard the dullness. After doing this, I would be palpating the spleen. I would lower my left hand over underneath the costal line of the rib cage, and then with my right hand I would be feeling the spleen. Normally with the spleen you will not feel or be able to palpate the spleen. If you do, it's enlarged. Now, for the sake of time, if I felt the spleen, I would have Dad turn to his right side. With the same hand positioning, I would be feeling that area, feeling to see is there any nodules, seeing what's going on. Now with the liver, like I said, you begin with percussion. Always remember, percussion is the identifier of the size. Think kind of like north and south. The south is your abdomen, the north is the chest. What you're going to be doing is you're going to be meeting at that liver area. You'll be starting with percussion around the mid-clavicular line, and you'd be hearing, or feeling the same thing till you come up to a dullness. Once you come up to a dullness, I'm not going to exactly mark, but you would mark that area. Now, some people on the outer edge, they like to use the mid-sternal, so the mid-sternal line, you would, okay. Once you heard that, you would mark it. The liver usually is found on the distal end, approximately on the 5th through the 7th intercostal space. On the proximal end, I would be feeling and marking the area the same way, mid-clavicular line. Same thing. And then I would have my liver size. Okay, with palpating the liver, what I would be doing, there's some different techniques. One technique is you would take your fingers, like on where you see the marks. Let's say I had a mark here and here. I would curve my finger around and with deep palpation feel the edge of that liver. The liver would be firm. If you feel nodules, then you know something's wrong. But that is one technique to use. Other people, they would put their left hand below the liver, lift it up, and then with one hand start feeling the liver, start in on the distal end to feel if there's any nodules or anything like that. And like I said, the liver should feel firm. Now with the kidney, it's the same technique, but I want to add a golden rule. For example, my dad has only one kidney. This is why it's always good on examinations when you're inspecting, ask. Okay, let's just say Dad's having problems with the kidney and I would assess. What I would do is I would put my hand underneath the kidney, raise it up, and I would be feeling the kidney. I would be trying to palpate, seeing exactly with deep palpation. I'm not going to do deep palpation on you right now, Dad, but I would be feeling to see if there's any nodules, any areas on that kidney that should not be there. And basically you would be doing the same way with the other. Now, upon saying that, let's state that Dad had ascites, which would be fluid buildup. With fluid buildup, you are going to be hearing you'll be hearing a dull sound, and usually it's dependent. Okay, with that, I would be percussing, and if let's say he had fluid buildup here, I would feel tympany up here, dullness down here. Okay, because usually you would hear a resonance or a tympany with air filled. If he had that, I would have him turn to the right side. The fluid would shift. And another thing, always you have a marker. I would mark the areas where the dullness began. I would have him turn to his right side, and when he turned to his right side, the fluid would shift. Well, upon that, I would be doing the same thing, percussing. But let's say he's on his right side and From the umbilicus down, I feel dull or hear dullness, but on the left lateral lower quadrant, I feel and hear tympany. Then I would mark here and say, okay, we've got this much fluid going on in the abdomen. So that's one way to realize if you've got this going on. Another thing is a fluid wave. Now what you need with a fluid wave, you can either have do one or two things. If your patient's cooperative, can work with you, you would have them use their arm, lay it down midway through their abdomen. If you don't, just have another staff member to help. I'm going to have Dad just hold his arm down here, and basically I would have my hands on his abdomen, and I'm going to tap with my fingers. When I tap, if he had fluid building up, guess what? I'm going to feel it immediately. I'd feel those vibrations, but I don't. So this is another sign of something that you would see. Now, I'm going to have Dad to do something for me. I want you to raise your neck up. I know we're skipping a lot of things, and it's out of order. If you would have masses, when you raise your head up, you would see like the muscles start tensing up, the rectus abdominis muscles, and you would see a change. So if like you feel a mass or you see something, you can tell by somebody raising their neck up just if this is superficial or if this is deep. Now I want you to sit up for me, Dad, and what we're going to do, we're going to check costovertebral tenderness. And what that is mainly, very simple, it's like an angle around the kidney. It's around the costal angle, around that curve, and then right the edges of the spine. Very simply put, you put your hand right here, around under that curve, and then I got my hand just straight out like on my palm on his kidney, on the flank. I would just gently hit. I wouldn't beat, but I did. And if there's pain, Dad would report off, I'm having pain. Basically, as you can see, there was no pain, and basically you can safely state that with proper abdominal assessments you can find a lot of different things because you're looking at some major organs. You would document your findings, everything like that. And with each individual, you'll see, as I have seen, that the more assessments you do, the more you can realize how this will benefit the patient. Thank you very much.